and I'm going to go ahead and put my phone on mute.
Okay. So it's 7:30 now, and I see that both of our presenters are here. Hi, Kim.
Hi. How are you?
Thanks for being here.
Sure.
And you see Nicole is here as well.
Yep. Hi, Nicole.
Hi.
So why don't we maybe just give it a couple more minutes
Sure.
before we get started, and folks could mute their microphones. I think that would prevent any feedback, cross feedback while the presenters are talking. But if you have questions, you can enter them in the chat, and then we can pause and take questions. Presenters, if you want folks to wait to do their questions later while you present, that's totally fine too, whatever you'd like. So we'll just give it another 2 or 3 minutes.
Sounds good.
Okay.
Where do you live, Nicole?
I was just going to ask you the same thing because I was going to say it looks beautiful there. I wish I was there.
Where are you?
I'm in Pennsylvania.
Where?
In York.
Okay, well, I'm in Chambersburg.
Okay, well, it looks a lot nicer there than it does here currently.
Is it raining there?
Yes, it was. I'm in my basement right now, but last I checked, it was not looking so nice outside. It was coming down pretty hard.
Yes, I was noticing on the news they were talking about York getting some bad storms. It just went through here briefly, and now it's all pretty and green.
Yeah, it looks nice.
Yeah. Yeah, I was telling Rebecca I didn't plan a presentation, so to speak. I was just prepared to answer questions. So
I kind of just put together a quick PowerPoint to keep me more focused than anything because I have a tendency to get a little crazy and scattered. So it was just kind of based off of the questions that she had emailed us.
So, well, Nicole, would it be better then if, Nicole, you want to go first so you can present and then
Sure.
Kim can go second? Okay.
yeah, that might be a great idea.
Okay, great. We'll give it another minute or so.
Where are you, Rebecca?
Philadelphia.
Are you getting some storms also?
Yes.
Yes.
Yes, the sky was pretty green a little while ago.
Yes.
Yeah. And lots of rain. We have flash flood and severe thunderstorm warnings.
Yeah, I was a little worried about the meeting tonight. I was like, I'm not sure if this is all gonna go well.
Well, we'll see.
So we have a few students, don't we?
Yeah, we do.
1, 2, 3.
Why don't we go ahead and get started? Just go from
Very
there.
nice.
I just want to thank you all for coming, and I think I know all of you. We do have Krista, who's a instructor from Frontier and Georgetown. Krista, is that right? She's on the phone.
Well, I'm a preceptor, but a nurse midwife in New York, and I actually know Miss Nicole.
Ah.
And met,
Hi,
and
Krista.
met him at ACNM. Hello.
Awesome.
The small world.
Yeah.
The small state. So I'm Rebecca, and I think I know most of you. We have the Students and New Midwives Committee that's been going for almost a year now. We've been holding monthly meetings. We've been doing some neat projects as a group. And one of the projects we wanted to do was to start having webinars where students could gather from across the state and outside the state and talk about issues that are important to students. And the students decided together that transitioning to the role of student midwife was an issue that is very important. Whether you were a nurse before or you weren't a nurse and you were doing something else, the role of student midwife is a unique one. And I think certainly I was telling Nicole this is a webinar that I wish I'd had as a student. And so we're very grateful to have both of you here tonight. And thank you. So feel free to get started.
Again, my name is Nicole Quintero. I am a midwife in York, Pennsylvania. I am a new midwife. I have been working now for just over a year. I graduated almost 2 years ago now. So while I'm going through things, if anyone has any questions, just feel free to interject whenever. So let me just pull up my PowerPoints. All right, does that work for you guys?
It looks perfect.
Okay. Okay. All right, so one of the first questions that I wanted to address was something about letting go of like being a nurse. While I understand kind of the question, I think that one thing that I learned quickly was that being a nurse for a period of time. I was a nurse for 15 years prior to becoming a midwife, and my background is in critical care. I have no experience in women's health prior to now, nor did I have any experience in like labor and delivery. I chose to be a midwife or become a midwife and a women's health nurse practitioner because when I had my daughter 12 years ago now, I had a wonderful midwife. So she clearly left a very good impression on me. So when I was in the clinical setting, everyone, not just preceptors, but the nurses that you worked with and the patients, of course, really appreciated the fact that you were a nurse and you could help, and that never stops. So just be mindful of the fact that you've worked in the clinical setting before, so it's nothing new. Just be confident because you guys are learning current information, research-based information. So be confident in what you're learning because quite frankly, you're probably more up to date on things than I am even. Once you get out there and you get working, it's a little bit difficult to sometimes stay abreast of, you know, what's going on. So let's see. Transitioning from a nurse to a provider has been a little bit tricky. I still don't know sometimes, you know, how I'm coming across or how I'm being received. I actually transitioned from RN role to advanced practice nurse role in the same hospital. So I think it was a little bit tricky. So I worked with nurses for a while. Everybody in the hospital kind of knew me. So now when they kind of are experiencing me in a different role, I don't know, I guess it's just been a bit of a weird transition. I guess easy as well because I have a pretty good rapport with most of the people in the hospital. All of the labor and delivery nurses were new to me, so that was good. Let's see. So I was in a program that set up clinical placement for me. I chose this program because I had started a women's health nurse practitioner program about, I don't know, probably 10 years ago now, and I had to take a leave of absence for personal reasons. And when it came to setting up clinicals, I had a very hard time. And that's a big issue for us as advanced practice nurses going to school is, we don't have the same resources that, say, I feel like physicians do going through school. So I lived away from home a lot of my program, and I did have very different experiences at every site that I went to. I think that you can take something away from everyone that you encounter. So whether or not you click and you're going to be best friends, it really doesn't matter. I got something from everyone. And, when you guys get out there and you're starting clinicals, especially, the nurses will be your best friends. They run things. So don't be afraid to, like I said, have a lot of respect. They know what they're doing, and be helpful. So I think it helps. Expectations while you're in school, just Rebecca was kind of talking before this started about being kind to yourself. Be kind to yourself. You will get through it. It's not easy. I was told, I remember this sticks in my brain when I started school, like, laundry will not be done. There will be dishes in the sink, and you kind of have to learn to let go of that stuff. Your family, understands what you're going through. And so when I put here, speak up, you have to tell your preceptors if something's not working for you. You have to tell your family if something's not working for you. I had to have the conversation with my husband time and time again about, like, I need more help right now. And he did his best. But you always, you just kind of have to just let people know what you need. Clinical resources. My school preached Pocket Brain. And I do love paper. I'm a paper girl. But I had these grandiose ideas about what I was going to do while I was in school. When I got out of school, I was going to do this, I was going to do that. These are the things that I use the most currently in the clinical setting. I have access to up-to-date in my position. I use that pretty much all of the time, especially when I'm in the office setting. I pretty much start my day where I open it up. I leave it open all day. I refer to it on a daily basis several times. So the learning never stops. I have my smartphone, which is a godsend. I use my OB Wheel app on it all the time, the ASCCP guidelines, the STD treatment guidelines, and also the CDC MEC chart for contraceptive use. These are the things that I use the most. I think everybody will kind of just have to figure out what's going to work best for them. Some people do like to carry cards around or books around with them. My phone and my computer in the office have become my best friends. Is it worth it to go through a dual program? I haven't figured this out yet, to be honest. I feel like what has happened is I took a position as the first nurse midwife at the hospital I'm currently working at, which at the time I was, even though I was the first, shortly thereafter, we had an experienced midwife that was hired, experienced to the tune of like 2 or 3 years. But I thought, okay, well, we'll start this program. And the idea was like, they were going to start bringing in other midwives. And I thought this could be really cool, like to start building a midwifery program. Not so much. just being honest. Everybody is awesome, and I can't really say anything bad about anyone that I work with, but they don't understand what midwives are. what we do. I get pigeonholed. So they do love the fact, oh, you're a nurse practitioner too? Oh, you mean you can do this? Yeah, I can do that as a nurse midwife, but they don't understand a lot of things. So I think one thing to consider is schedule. When you're a midwife, women have babies all the time. So if you're looking for like that Monday through Friday ideal schedule, it's probably not going to happen. It can. I mean, I'm sure those midwifery positions are out there. I actually did work with one midwife when I was going through clinicals who had a very kind of standard schedule. She did not do any deliveries anymore in the hospital. She had been working for years, so she just saw patients in the office. But I think I kind of talked myself into doing the midwifery thing for at least a couple of years to see how I was going to feel. I would say for my career as a nurse, 90% of it, I worked nights. You know, you get used to working nights, weekends, holidays, and I can't say that the idea of potentially having a more standard kind of normal schedule moving into the future isn't something that's attractive to me. And I think that positions as a nurse practitioner are probably going to be more suitable if I'm looking for that. The one interesting thing that I've kind of encountered, light situation here, is that I am a nurse, a midwife, as well as a nurse practitioner, and the midwife that I work with, for whatever reason, I don't know if it's a comfort level, but she's just not as comfortable working with like GYN patients or kind of like, you know, triaging GYN stuff at the hospital. So I feel like what's been happening is a lot of that stuff has been falling on me. So they'll come to me for certain things. You know, it's just funny. It's funny how it's worked out. But I'm pretty comfortable just going and seeing about something. So if they call me and I have no idea, I'll go and see if I can figure it out. I mean, there's always going to be someone there to help you. So I had a big gap between graduation and working. My program was didactic and clinicals all the way through. We didn't have anything split. So I graduated in August of 2017. I took my boards in early October and I took them back to back. So I took the midwifery boards in the morning and then the nurse practitioner boards that afternoon, because I thought to myself, if something goes down, like, I don't know if I'm going to be able to like muster up the courage or the energy to go and do this again. So I went and did it all in one day. I got offered a position in December of 2017 and kind of fell through the cracks because there was a change in the computer system at the time. So licensing and then all of that stuff took quite a while, credentialing, etc. So what I did was I knew I was hired in December and they wouldn't let me touch anyone, but I started spending a day at the office, pretty much I think in maybe January or February, and I was just there and they were introducing me to patients saying, you know, this will be our new provider, and I was getting to meet people. That was good for me. I was still working as a nurse, but I was working as a nurse in the CCU or on tele or wherever they needed me in the hospital. So one of the things I guess is if you guys don't have positions where you're working on L&D, you know, maybe if you can, you know, shadow on L&D here and there, something to look into. So professionally, I think it's really important to know your state-specific laws. And then this is kind of something I had touched on, like consider who you're going to be working with, because like I said, there's just a lack of knowledge about midwifery in general. where I am. And I do wish that maybe I had taken my first position with, where I had surrounded myself with experienced midwives who could have mentored me, because really, yes, I got it throughout school, but I just needed more. I needed more of that nurturing from experienced midwives. So, and then, so I have a picture. I don't know if everybody can see this, but, I just kind of wanted to run through things for people just so you guys can relate. Like, I did my first clinical setting close to home. It was in a very nice office. The clientele were more affluent. Then I left home. I was kind of commuting 2 hours away. Very different patients. We were seeing a lot of younger moms, a lot of drugs. My third clinical semester, I actually lost placement in the middle of the semester. My school luckily was able to get me placement at a hospital closer to home. But that was very different as well. It was a big hospital. The patients were definitely higher acuity. And then my last semester, I pretty much lived in the Poconos. So the picture on the left is my first delivery. And then the picture on the right is I just got to deliver my best friend's son. So we grew up together. She's like my sister. That was pretty awesome. And yeah, that's pretty much what I have for you guys. If you have any questions.
I think Fanta asked a couple minutes ago, does your facility provide up-to-date? Is that right, Fanta? You were asking?
Yes. As a matter of fact, Fanta, you have access to it as a nurse. I can show you how to get that. It's actually very nice that they do that.
Andrea is asking, are you at Memorial with Kristen?
Yes. I just want to, is there a way I can see the questions from people?
Yeah, so if you just click on the chat, there's just been a couple. And then folks, if you want to just ask your questions by unmuting your microphone, you can do that too. It's a good sized group for doing that. So that's perfectly fine if folks want to do that.
Nicole, it's Krista. Did you know you can get CME time for the up-to-date?
I didn't.
Just found that out last year.
That's awesome. I did not.
Yeah. Make a login, and you can get CMEs.
Wow. I can probably get a lot because I'm on there all the time.
It tallies up as you go along. You'll be shocked. You'll get hundreds.
Yeah, that's amazing. That's great. Thank you.
Nicole, I wondered if you could say a little bit about this idea of finding your voice as a student midwife. There was so much in the program that I just graduated from. There was so much talk about it, but it was like this, it was like the golden snitch in Harry Potter. Like it was this ethereal, evasive thing that kind of kept flying all around. Professors kept throwing it out, like, find your voice, find your voice. But I think it's challenging when you're trying to negotiate lots of different preceptors with lots of different styles, and you're observing and you kind of don't know where to tuck yourself in, and you're also trying to figure out your own identity as a provider. Can you speak to that a little bit?
I think I'm still trying to find my voice now as a new midwife. I guess it's coming along. I think that also was one of the hardest things for me being the first midwife hired on. So you start working I was working with residents. So essentially, I think that what happened was they were looking at me as just another resident. And they were kind of mentoring me, just kind of, this is how things run here type stuff. And this is what we do. I think I'm just starting now, and again, I'm just over a year in, to kind of say, well, you know what? This is how I feel comfortable managing this patient or this situation. And I'm okay with saying that. I in the beginning had a very hard time because I'd go to reports and I'd kind of sit there and wait for them to critique me and tell me, well, you should have done this, or you could, and it was never you could have done. It was you should have done. This is what we do. And there's so much gray in this area, which for a person like me can drive you a little bit crazy. I'm usually very calm on the outside, but on the inside, I'm like, oh. There are so many ways, following guidelines, there are so many ways to get from point A to point B. And I just really feel like it's a time thing. I feel like it just takes time for you to become comfortable doing that. So
thank you. That's a great answer.
So how does that affect your professional relationships, especially being, the new kid on the block, and you're saying, no, I think I'd manage this way instead?
I feel a lot stronger than I did a year ago. I sit in report now, and, I think that it was really hard for me to kind of assert myself as the provider. I am the provider who's done with school. When you are done with your residency program, I had a lot of issues with the residents. They were nice. It wasn't that they were ever rude or mean. I think there was just a total lack of understanding. And I think that it goes for anything else in life, when you can sit and you can have a reasonable, civil conversation with someone just about things, I feel like I've been well received by them. When I can kind of it takes me a while. It takes me a while to kind of figure out maybe if something's really bothering me, how to approach it, in a way that's going to be effective. So.
I have another question while folks are still thinking about their questions. When you were a student and you were working with different preceptors, thinking back on that experience, now that you're a midwife and will probably be a preceptor one day, if not,
I actually am precepting someone right now. Funny enough, she's an FNP student. She just started with me. I figure there's something to be learned. I don't know. we get through our days.
So I guess my question is, what would you have given yourself when you were a student? What would you have done for yourself if you were a preceptor to yourself, if that makes sense? Like, what did you need from your preceptors that maybe you didn't get that you are going to give to your students as a preceptor?
Well, I think that everybody learns differently, learns best differently. So funny enough, I actually respond better to a person who is a bit more aggressive and excuse kind of more of a hard ass. Like, this is, you need to do that. You need to get the stuff done. They always want to know, they'll ask you questions. They'll kind of quiz you all the time. They'll hold you accountable. I respond better to that. It may not feel the best in the situation. I can't say that I didn't have times when I left clinicals in tears, because I did. Not all the time, but sometimes. It's good though. You need those humbling experiences. And like I said, with my current student, I kind of asked her in the beginning, what do you respond to best? So I think it's just an individual thing. And I would thank the people who were kind of, like I said, more aggressive with me.
Are there any other questions for now before we switch over to Kim, and then we can come back to discussion?
This is Krista. Can I add something to what Nicole just said?
Of course.
Just because I have been precepting now for about 3 years, and I think it's important for you to be able to share when you're starting that experience with your preceptor, because Nicole's right. They're just like students learn differently. Preceptors, some are good at being real hard asses, if you'll pardon the expression. Some people are just kind of sit back and let it be. And I think you have to be able and be ready to have a conversation with somebody to say, this is how I think I would learn the best, or this is what I feel I really need to focus on. And then give yourself the gift of checking in a couple times during each rotation, or however your program divides your clinical time. But I think you owe it to yourself. Do yourself that favor, because not every preceptor is a good preceptor. That is also a very big reality.
That's such a great point. I wish I certainly, as a student, and I mean, I'm so close to I'm not out of school very long, and I certainly wish I had done more of that. And I wish we'd had more of those touchstone moments when we could take stock and say, how is this preceptor-student relationship going? Are you getting what you need? Am I doing what you expect me to do? And I second that advice. I think I would have actually gathered some confidence from that kind of having those kinds of interactions more.
I do think, though, for people who haven't entered clinicals yet, this is not to scare anyone. I think it's very important to remember, though, like Krista said, not every preceptor is a great preceptor, but you'll get something from that person. So it might be a negative experience, but you will get something, or you will have gotten something from everyone that you come into contact with. So don't be scared. It's learning.
Awesome. All right. Do we want to switch over to Kim? Kim, you want to tell us a little bit about yourself and your background? And
yeah, this is a perfect combination, Rebecca, because Nicole and I have very different career paths. I love it. And I always say, if you've seen one midwife, you've seen one. There are similarities, but there are big differences, which is just the greatest group you're ever going to be involved with your whole life. I come from a very different place. I came to the nursing profession through the executive side of hospital administration. So I did that in Washington, D.C. for, I think, 12 years or so. I have a master's in hospital administration. The last assignment I did as a director in a community hospital was recruiting midwives. And to tell you how long ago that was, we were at a conference, and whoever was presenting talked about having 10,000 midwives by the year 2000. Well, this is 2019. I think there might be 12,000 or something. But anyway, and I literally looked to the consultant sitting next to me in my administrative role, and as my friends say, the business suit, the heels, the whole 9 yards. And I said, do you think I can do that? And she said, you most certainly can. So I had no clinical experience whatsoever, totally regrouped, and retrained and became a registered nurse, and now I'm a midwife, and I just have been accepted into the midwifery doctoral program in the fall at Jefferson University in Philadelphia. I love it. This is the career for me. And in fact, most of my experience prior to being employed is out of hospital experience. I'm a home birth mom myself. I did birth center and home birth mostly. In my training. I call myself a sellout midwife because I'm a U.S. public health scholar. So I took this job as a loan repayment opportunity for 2 years. My loans are paid off, and 13 years later, I'm still at the same place. I love it. So I come to the profession understanding the business of medicine, so to speak. understanding the roles within nursing and medical staff. And in fact, the practice that I was helping recruit, the practice exploded as a result of midwives. If a physician doesn't like midwives, my experience says they never will. So I was very aware of the conflict and the competition between these two levels of professionals. And I decided that I would never go into a practice and be the first midwife. Nicole, you are one serious midwife. Congratulations, you did it, girl. Because I've seen that happen. I've seen the physician be up in the midwife's face. You're not a physician, how dare you? And I knew I did not want that. So the practice I'm with is Keystone Health, and it's a federally qualified health center in Chambersburg, Pennsylvania, South Central Pennsylvania. Our CEO is a nun, or was a nun. She left the convent after 20 years. I think they were unable to teach her humility or something like that. So after 20 years, she finally left, and we're glad she started Keystone. So I came with a pre-established group. Also coming in to the group, I was the third. The first midwife was fired because she didn't know her place. So that tone was set right out of the gate. The other two midwives I was working with had been nurses, and so their experience was a little different than mine. I always say I borrowed the profession of nursing to become a midwife, and through that process have come to love nursing. And that's why I teach as well. I teach nursing students at a local college. But anyway, I did understand that relationship. And so I knew that the midwife was accepted there because they've been there for a long time, but I'm not convinced that most places really know what midwives are. We're always having to teach someone. And even the women we serve love us. But when you speak, you hear their language, I'm going to the doctor's today. You know, some of them have never seen a physician. They've only ever seen the midwife. So I'm one of 4 midwives. I do have one of those really good jobs that it's a day job. And it's just because this is how the practice is set up. They already burned through a couple of other midwives because the pace was too difficult. So since I've been there 13 years ago, we have not changed the schedule. We work 4 days a week. Every 4th Sunday night is a 24-hour call. 2 days in the office and generally 2 days of call. And that call is 7 in the morning to 6 at night. We behave as a laborist, 4-hour practice only when we're on call. If you're within 30 minutes from the hospital, you can take call from home. If you're running Pitocin, you have to be within 5 or 10 minutes, I think. So we take first call for our practice. We don't risk anybody out. We share absolutely everybody evenly. So it's an incredible model. The senior physician has been practicing for 30 years. He's a wannabe midwife. I mean, there's no doubt about it. He's a surgeon, but he is so supportive of us. And our chair has been practicing, I think, 18 years, and she is also unbelievably supportive. We have a voice at our hospital. We sit on the medical staff, but we don't have a vote. And that's typical in the state of Pennsylvania. I happen to be on the board of the PA-ACNM. I think political action is vitally important. You can't stay out of politics when you're a midwife. And you'll realize that soon enough. I always accept whatever seat at the table I'm offered, even if I know nothing about it, because then they have a face of a midwife and they become more comfortable with who we are. And that's important. So you teaching all the time. And I think that's what we do best. So anyway, that's my career, my experience, and I love it. I think the role change is different. And I see that I take midwife students all the time in the office. When you've been a nurse for a long time, sometimes the history and physical and the intake is from the nursing side of things. And you'll have a new student that wants to ask about every ache and pain that person has. We are really zoning into that well woman OBGYN, that GYN exam often. I do lots of GYN in my practice, so I wonder if it's just Nicole, it's your colleague. She doesn't have a lot of experience, but kudos to you for stepping up and sharing yours with her. I mean, you're just amazing. But we can't lose you if you're talking about becoming a nurse practitioner. We need to keep you as a midwife. And one of the students is a nurse at our hospital who has wanted to be a midwife forever. And I'm so happy to see her. Yasmina, yay. So anyway, I was a little less formal than Nicole, and I'm open to questions. Whatever you guys want to hear about is the right thing to talk about. I will often say to students that sometimes I've been saying the same thing over and over. So maybe I'm lying. I'm just making it up. So if you figure out that I'm lying and making something up, call me on it. And then we'll both look it up. And I'm like, oh my gosh, I didn't realize that happened a couple years ago. I think that's the most important thing. Was it Fanta that talked about how to get your voice heard? Use your research. You have all of the evidence. The evidence supports. This study supports. Take a second and look it up, how you know that. And I mean to tell you, there are few professionals as well read as midwives. Physicians will often stop reading after residency. Midwives never do. So once you talk to them about the research, they're sold. That's my experience. So what else might you want to know?
So I have a couple questions. So I haven't reached clinical just yet, but I'm wondering, as far as what the clinical experience looks like I have a family, I have, just different things going on. Are preceptors pretty flexible, or it's like, no, you have to follow this schedule and that's it?
My guess is that's individual. I recognize the number of responsibilities the student midwife has, and I always encourage my students to get all of their work done in clinical, write their soap notes, as much as they possibly can do, because the patient is there, the resources are there, and you're not the extra help. So I really encourage students to be a student and take advantage of the time. If you have an interesting patient, look up everything about that person. You'll never get that chance again. I would say that's something, we all wish we could look up a little bit more, but you only have so much time. So take advantage. You're not expected to see the volume that the experienced clinician is seeing, nor should you. You should pick and choose. You can go along and observe if you want, but take advantage of being the student and pick somebody interesting to you.
Okay, thank you. And then also, say, I'm through with school, I'm interviewing. What would you say, like, the greatest highlight you would use as to talk about yourself as a midwife, right? So, I'm a midwife, you're a midwife, but what's gonna help you stand out a little bit more? And I do realize that's a little individualized.
Yeah.
But just kind of, if you can generally speak to that.
For us, we're a busy practice. So we don't have the luxury of that midwife schedule. They teach us all about those half-hour, 45-minute, hour schedules. Midwife-only practices often have that, but when you live with the physician, they want you to see the same amount they do. Mm-hmm. And I think we can do it. I really do. You get good at it. But for our practice, it's somebody that's flexible, because things are changing, meaning processes change, computer systems change, the composition of your group changes. Be flexible to that and be open. Do not be a doormat. Don't ever be a doormat.
Okay. All right, sorry.
I always, yeah.
So when we're talking about like something about negotiating schedules and salaries and stuff like that, once you have been offered a position, what does that look like?
My recommendation is you talk about yourself. Don't talk about your family, what you need for your family, financial resources, things like that. That's really not the concern of your employer. You are selling yourself as a midwife. What do you bring to the table? What will make your life manageable? I would like a schedule that is. Just be firm about what your needs are. You know, you're not going to find a lot of day jobs. This just happens to be the practice. You are, have to be willing to do call. You're working generally with people that are working 24/7. They're never, I've not met many obstetricians that are, super empathetic to being tired. I don't know about you, Nicole, but the doctor is the doctor. If you know what I'm thinking, they are the doctor. And I think you have to be respectful and mindful of that. They did study for 12 years, but they're a different professional. We're not a wannabe doctor or wish we could have done it. We've made our choice. This is what we want to do. So just whatever it is you need, lay it out there.
Okay.
They can either accommodate you or they can't.
Okay. Thank you.
Kim, Michaela has asked, what is your, I guess this is for either one of you, what is your opinion about fellowships?
I think I think a fellowship would be invaluable, but I actually had looked into some. They're not easy to come by. Like, it's hard to find. I mean, if you've got the freedom to go and do what you want to do when you're done with school, that's awesome. I am, I'm a mom. I didn't have that kind of flexibility. But I think that it could probably be a wonderful experience.
I would agree. I did a perinatal fellowship to become a labor and delivery nurse, and I found that to be invaluable. And it was an experience as Nicole described, and it was a major tertiary care facility. But that learning I would have never been able to pick that up anywhere else. And I'm glad I have it. So those are the meanest people I ever worked with, but now I got over that. Those big academic medical centers.
What was that?
Those big academic medical centers, they're tough.
Yeah. Oh yeah,
they're just tough places.
I know we have at least a couple of folks present tonight who did not work as nurses before. And I was wondering if you could speak to whether you experienced any challenges from preceptors who had worked as nurses, or if you experienced difficulties finding a position because you had gone right from the nursing education to the midwifery education. How do you negotiate differing perspectives on the path you should follow versus the path you followed?
Is that for me?
That's for you, Kim.
Yes. And it is a different path. And the two other midwives that I work with now, no, one of them, sorry, one left. She and I both have the same background. We came to nursing to become a midwife. I just don't find it to be a transferable skill. The nursing profession considers it to be, but it's not a transferable skill with midwifery. And I was lucky. When I was in nursing school, I got a job as a nursing assistant in a brand new hospital that was a March of Dimes breastfeeding friendly hospital. So my job every Friday, Saturday night was helping women breastfeed. So I didn't bluff, but I knew nurses expected experience. And so I would speak of those experiences, and they thought I had more nursing experience than I did. So, because I knew the culture, and I knew when you're new, you can just only handle so much negativity. I mean, you're just trying so hard to be a new practitioner, and I've done this and done that. And they never really asked detailed questions. But then I did work in labor and delivery as well. But it was, I was part-time when I was a student.
I will say that going from nurse to, midwife, the one thing that's been difficult for me is when you've been a nurse for a while, not that I don't walk away, it's just harder for me to walk away. It's harder for me to like leave the unit, it's almost like, well, I have to be here. There are patients, which I mean, I do have to be there, especially if something's going on, but, I don't need to be there to answer call bells and stuff. I think that though that's just kind of in me. So that was a little bit, it's been a little bit more difficult to separate myself. Not that I mind, but I have to say it really wears you out. It wears you out because then you're kind of trying to like split yourself between two roles. And that's something that I think has gotten a little bit better, but I still have to work at every day.
Sometimes I wonder too, is it gender? Sometimes we're just more helpful by nature. And when you've been a nurse and you understand all the demands they have, you do try to only ask them to help you if you need the help. Like you tend to clean up things yourself or get things yourself because you recognize they're busy too.
Yeah.
Just looking at the chat to see if there are other questions. What about, while folks are pondering, what about when you are in a clinical situation where you have lots of different preceptors and you're trying to work with each of them differently and learn what they have to teach you, but also manage that what they teach you might be different than what another preceptor at the same place teaches you. Any thoughts on that?
I think I think it's good to learn that straight off because we kind of touched upon like there's so much gray. So it's going to be like that your entire career, I feel. So that's a good thing to just learn. I do understand what you're saying, but kind of speaking to Fanta's question from earlier about flexibility, it provides you some flexibility because in terms of schedules, if you're working with a bunch of different midwives at a practice or at a hospital, you get that, so that's a pro. But as a student, it can be hard, kind of hard to kind of work through a lot of the information. I think you always have to remember as a student what you need to, be able to, I don't want to use the word regurgitate, but I mean, essentially when you're taking exams, etc., that information you kind of have to keep separate from what clinically is, while it's a foundation, it's your foundation, but clinically things happen and it's not always going to be by the book. So.
And sometimes we don't know there's differences between us. And certainly if I had a student reference how a colleague did something, I would be interested in knowing it and just sort of explain why I do what I do. But I'm with you, Nicole. There's just many different ways to do the same thing.
Yeah. Yeah, and I mean, even working with my current student, like, it's great for me. It is a whirlwind. You get out of school, I'll admit to you guys, and I'm pretty much right there with you guys. I'm not out that far. You get out of school and you're kind of like, oh, I can kind of breathe a little bit for a little while. I'm trying to get settled in my role as a new provider. So having to work with someone and having to really think through things and explain has been great for me. So I think that I hope that everyone that you work with will kind of feel the same way. Like, you are valuable as well, like, to them. So, I see it that way, but.
Are there other questions that folks want to ask? If you can type it in, or you can just ask, unmute your microphone and ask. I think Elizabeth, we can't hear you. Can you try again? So Elizabeth is asking, the hospital I work at as an LDRP nurse will soon be hiring midwives. And she says, I've pondered the pros and cons of being a new midwife in this setting.
Do you know why they're hiring midwives?
She says, in a new setting where midwives have not previously been welcomed with open arms by any means.
Ooh, boy.
Because it's like you touched on before, Kim, they've come to realize that we are very good for them. I mean, you know, they can't deny it anymore.
Yeah.
And as much as there may be, you know, physician pushback, people want to come and see us. So
Elizabeth is asking, she's talking about being in a situation where a new practice is interested in midwives while another practice that is also on the same floor is very against midwives. So being in that crossfire, is that right, Elizabeth?
Yeah, that's a tough spot for a new midwife, for any midwife. Like I said, I wouldn't take it, but the other practice, they'll probably be fascinated with what they see, and you know, you just be as professional as you possibly can to everybody, and they end up liking you. But if you join a practice where the physicians in the practice don't want a midwife, oh, that's a tough one. That's a really tough one. Yep, you're right. There is a mixed bag in how nurses perceive midwives because they're involved in the medical model in many instances.
And then
in terms of, I was just going to answer her question about applying for jobs. So you have two types of people. You have like type A who are going to be the ones that have a job lined up before they take boards. I have my family. I was still working when I went to school. I was kind to myself in that respect. I graduated, I took my boards. When I passed, I was like, okay, I'm gonna now start applying for jobs because I still had my job as a nurse. So I mean, financially, I don't know what people can and cannot do, but I didn't feel rushed. I thought if I apply for a job and am offered a position now prior to taking boards, if I fail, like I think there would just be more pressure added, and I didn't want to add any more pressure than what I already had. So I feel like I was able to do it up until a certain point. I think the funny thing is that when I was in school, like I said, we kind of had didactic and clinicals were integrated the entire program. So, you know, towards the end, I was having classes with some of like the CCU or the critical care NP students. And I think they were all amazed at the amount of clinical time midwives are required to, you know, complete. So that being said, when you start getting into the antepartum realm with clinicals, I had to drop back my hours. So while I was able to maintain that, maybe when I was like going through like a primary care or GYN rotation. When I started getting into the OB stuff, I had a rough time because, you know, babies are going to be born when they're going to be born, and depending upon your clinical site, if you're working at a very busy or with a very busy practice, and you're going to be getting, I don't know, several births a week, then you might be able to do it. I was at a couple of sites where, you know, I kind of had to be there, you know, for when the getting was good. So.
I'm sorry I was late getting on. I currently work as an L&D nurse and an LDRP as well. Would you guys recommend anything? Like, I've always been interested in doing spinning babies, but haven't had a chance to. Not too far off, like in hours wise, getting like IBCLC. Are those things I should be pursuing, or just kind of go with the flow?
I don't think you need the IBCLC because it is in the midwifery curriculum.
Okay.
But the spinning babies, you might get that in a clinical experience.
Okay. Thank you.
Mm-hmm.
Jen, I just wanted to mention there's also a really wonderful mental health for the reproductive years continuing education module that ACNM offers, and I loved it. And if you're interested in psych at all as a midwife, it's really, really worth doing. So I'm happy to email with you about that if you'd like.
Yeah, thank you.
You're welcome. Any other questions or comments or fears?
What a great group, Rebecca, and even on a summer evening.
I know, a stormy summer evening.
That's
I guess
midwife for you.
One final question I might ask both of you is, how do you start cultivating self-care as a student midwife that you can then translate into your profession as a midwife? Like habits that will keep you sustainable, keep you from burning out, or at least lengthen the time between starting and burning out.
I had to pause because I can't say that I'm good with that yet either. I think, you know, having young children, etc., it's hard. I think because of schedules, and there's been a lot of how shall I say, there have been changes to my schedule quite frequently over like the course of the year, and just when I was kind of getting into a groove come July, we're changing that again. I was just trying to find, like, kind of carve out time for me. It's just hard when your schedule is ever changing, and so I think though, in saying that, I have kind of been adamant, and my schedule is changing in July because I want stability. I want to know every week, at least if I'm working, you know, 24-hour call shifts, etc. I just want to know, on this week I'm working these days, the next week I'm working these days. That was my biggest request. I am definitely a team player, but I was definitely getting tossed around. I was the doormat. I am the doormat still. I'm trying really hard.
Oh no.
To not be that. I think stability just in schedule, it would be helpful. to be able to carve out the time for yourself?
I think priorities, you know, family and you have to be the priority. If you give it all away, you have nothing left for anybody. And I think you just have to remember that you are the priority and your family's the priority. And it's hard, but you've got to do it. And I say this because I come from the administrative side too. I think just be careful that you talk about what you need. I just think that people don't want to hear about your personal issues, so to speak, because we all have them. What do you need as a professional? What I need is a schedule that can allow me to plan my week. I mean, that's a really mature way that it sounds like you did that. You recognize everybody needs a schedule. And people appreciate that. Then you don't get into this argument of, well, I do it and the other person works all these hours. That's immaterial. What will keep you healthy? Meditation, I've been doing for a long time. Boy, does that help. Does that help a lot? I knew a midwife that wasn't particularly religious, but it stuck with me. She walked through the chapel at the hospital every time she was on duty and felt like that was a powerful experience for her. She felt that it was a privilege to be doing what she was doing, and it was just a little extra. And I've done that a time or two, and that does help.
That's awesome. I love that.
It is powerful. Yep, keep good care of yourself.
Well, thank you, both of you.
Thank you
so
for the
much.
You're welcome.
I appreciate all of you attending tonight. I appreciate everyone asking their tough questions and coming to this webinar with humility and all of our fears. And for both of you, I think one of the most powerful things in being a midwife and a preceptor and a professor is not forgetting what it's like to be new at this. And I just think that's so, holding on to that empathy, that's so special. It's probably what makes you both really great preceptors. But thank you to all of the students for attending. This has been great. Like I said, we did record it, so we'll soon be posting it. So if you all had colleagues that were not able to attend, fear not, we'll be making it accessible soon. Thank you again, everyone. Be safe.
Thank you, ladies, and
you.
good luck.
Thank you.
Good luck to you both.
Nice
Good luck
to
to
meet
you,
you.
Nicole.
So glad you're all here. Yay.
Thank you, Kim. Thank you, Nicole. Good night,
Bye-bye.
everyone.
Bye.